so that we are starting the main part of our lecture. Okay, great. So let's dive immediately into the optic neuropathies. So as I always said, optic neuropathies can be one of the very challenging differential diagnosis in ophthalmology. Like there is in ophthalmology more than 100 diseases that may cause optic neuropathy. So does we need to know every one of these 100 disease? Of course not, because the common is common, and you need just to have like a plan how to think of a case of optic neuropathy. And in the exam, when you are facing a case of optic neuropathy, so you have to need some clues to have organized thoughts about what will be the main features of everyone to in order to answer the case or to solve the case. So for patients with optic nerve disorders, well, the optic nerve, you may say, okay, what will be the most common optic nerve disorder? Can you tell me what is the most common optic nerve disorder in chat box? Dr. Ahmed, it is not there is no a cause, but there is the difference is that in the choroidal melanoma it is hyper dense in T1 and the hyper intense in T1 and the hypo intense in T2. This is the nature of the tumor. There is no cause here. Exactly, Dr. Wala. It is the glaucoma. The most common optic neuropathy is glaucoma. So don't ever forget that glaucoma is an optic neuropathy. Okay, so we are now discussing the neurological. So we are leaving the non-neurological now, which is the glaucoma, and this will be left for the glaucoma lecture. And we are going to cover the neurological visual field effects. So what is, if you are speaking about what we are saying that the glaucoma is optic neuropathy, so what is meant by optic neuropathy? An optic neuropathy is meaning that doesn't always mean that the optic disc is abnormal. Yes, Dr. Ahmed, the choroidal melanoma is hyper intense in T1 and hypo intense in T2. So remember that it will be just the reverse of the color. When the vitreous is black, then you will find the choroidal melanoma is white. When you find the vitreous is white, the choroidal melanoma will be black. So there will be always a contrast. Okay, back to the optic nerve disorders or optic neuropathies. So actually, the optic neuropathy doesn't always have to be with abnormal optic disc. Like for example, in retrobulbar optic neuritis, it is still an optic neuropathy, but doesn't show abnormal optic disc. But the meaning of optic neuropathy that there is impaired optic nerve function and associated with a visual loss. So if there is visual loss associated with impaired optic nerve function, such as color vision, this is called an optic neuropathy. So what are the different kinds of neurological disorders affecting the optic nerve? It could be optic neuropathy, papilledema, or benign intracranial hypertension, some congenital anomalies, and optic atrophy. So let's see what is the different terms below each entity of those. For optic neuropathy, it could be inflammatory, could be ischemic, compressive optic neuropathy, infiltrative, traumatic, toxic or nutritional, radiation, and hereditary optic neuropathies. So all these are causes of optic neuropathies. There are important optic neuropathies that are further subdivided, like inflammatory, can be demyelinating, which is the most common. It can be neuroretinitis, para-infectious, infectious, or non-infectious. These are the causes of optic neuropathies or the inflammatory optic neuropathies. For the ischemic, it can be either anterior or posterior ischemic optic neuropathy, or it can be diabetic papillopathy. For anterior ischemic optic neuropathy, it is further subclassified into non-arthritic ischemic optic neuropathy or arthritic anterior ischemic optic neuropathy. So these are the classification of the optic neuropathies. There is a specific entity of pupilledema or benign intracranial hypertension. And there are a lot of congenital anomalies. If you want to summarize them, there will be like tilted disc, the optic nerve head drusen, the optic disc pit, the myelinated retinal nerve fibers, the morning glory syndrome, the optic disc hypoplasia, megalopapilla, and the Burgmeister papilla. So those are the most common to appear in the exams. And finally, the end stage of the different kinds of optic neuropathies will be optic atrophy. So the optic atrophy can be primary, where it will be not preceded by optic disc swelling, or secondary, where it will be preceded by optic disc swelling, consecutive when there is another disease such as consecutive optic atrophy resulting in from secondary retinal disease, or glaucomatous optic atrophy. Or finally, a hereditary optic atrophy such as the autosomal dominant or recessive or Leber hereditary optic neuropathies. So this is just a summary of classification of optic nerve disorders. In the exam, when they are the optic neuropathies is very, very, very hot topic in the exam. Like it's asked in every ICU clinical exam. In the previous FRCS2 exam, it was asked in 3 questions. 3 questions out of the neurology or out of neuroophthalmology. They are asked specifically about the optic nerve disorders. So it is very important to give them an utmost importance. So if you are speaking about optic neuropathies, we said that it is associated with impaired optic nerve functions. So what are the optic nerve functions that are going to be impaired? The optic nerve functions or the visual functions are consisting of visual acuity, the color vision, which can be measured by Ishihara plates, or the red bottle of mydriatic or the bottle of the mydriatic eye drops. Contrast sensitivity, which can be measured by different contrast sensitivity charts, such as the Peli-Robson contrast sensitivity chart. The light brightness, which can be measured by a pen light, and pupillary light reflex, which is measured by the pen light. So why it is important to know this? Because if I'm going to tell you that there is impairment of the optic nerve functions, there is impairment of the light brightness, or there is relative afferent pupillary defect, or there is impairment of the color vision, you are expecting that there is a problem in the optic nerve. So you should look for a problem in the optic nerve. Okay, this is very important for the exam. Okay, let's start by the most important and by far the most common optic neuropathy that appears in the exams, which is the demyelinating optic neuritis. So we are speaking now about the specific entity of optic neuropathies, which are the demyelinating optic neuropathy. So we will try to analyze the different aspects of this disease, and we know the common areas that are asked in the exams. First of all, how to suspect a patient with demyelinating optic neuritis? Well, first, it will be in the middle age. So usually it affects the patients between 20 to 40 years old. And the most of patients are females. So most commonly, the patients are females of middle age. Okay. So what will be the onset and the course and durations? We have the 2/3 rule is still valid with us. So 2/3 of patients are female, 2/3 of patients are presenting with unilateral acute visual loss, 2/3 of cases are retrobulbar optic neuritis. So it involves the retrobulbar part of the optic disc, not the optic disc itself. So we can classify the multiple sclerosis demyelinating neuritis into papillitis, where there's inflammation of the optic disc, and retrobulbar optic neuritis, where there is inflammation of the retrobulbar portion. So here we have words that you may read in the text and you just don't understand that the course of the demyelination or the multiple sclerosis is remissions and exacerbations that are separated in time and space. So what does this mean? It means that the attacks or the exacerbations of the multiple sclerosis are characterized by symptoms, that these symptoms are reflecting the CNS involvement, like visual symptoms, like there is affection of the throat causing dysarthria, dysphagia, muscle weakness, spasms, ataxia, some involvement of the sensory system causing pain, hypothesia, paresthesia, involvement of the bowel system causing incontinence, diarrhea, constipation, or incontinence or frequency or retention of the urine. So this is what's meant by multiple. It is multiple affection of multiple sites present in the body. Okay, and this symptom or these symptoms are episodic. This is what's meant by it is remissions and exacerbations. They are separated in time and space, meaning that they are episodes that occurs months or years apart and affect different anatomical location. Let's see this graph. So this is the graph representing the frequency and the relapses of the multiple sclerosis. So this means that the patient starts, then he has remission, then he has exacerbation. This like exacerbation, after 1 year, he has another exacerbation. And after another year, he has another exacerbation. So they are progressive with relapses and exacerbation. So these are separated in time because it appears every year. So what is meant by separated in space? Meaning that in one attack, it may involve the eye. The other attack may involve the urinary system. The third attack may involve the musculoskeletal system. So space meaning that they affect different anatomical locations. Okay. So they are separated in time, they are separated in space, and even this separation is having different patterns. So they can be progressive relapses, they can be a secondary progressive multiple sclerosis with initial relapsing, remitting disease, then followed by areas of begin to have a decline without periods of remission, or it can be primary progressive multiple sclerosis. So there is no remissions here, or it can be relapsing remitting multiple sclerosis with unpredictable attacks. So it can be have any time, it can leave any residual deficit. So you can see here the patient doesn't return to the baseline. He always have some activities here, or he always have some neurological deficit. Okay, so for those patients, again, our 2/3 rule here, that 2/3 of those patients will present with visual symptoms or ocular affection for patients with multiple sclerosis demyelinating optic neuritis. So what are these clinical presentation? So in order to describe what is the lesion, you need first to know what is the pathology, what happens in multiple sclerosis. In multiple sclerosis, there is affection of the myelin sheath. Affection of the myelin sheath leading to demyelination with a scarring of the myelin sheath. And this myelin sheath is responsible for transmission of the nerve impulses. So if it's affecting the optic nerve, it will cause optic nerve loss or visual loss. So those patients present with acute visual loss. This is one thing. And around 90% of those patients will be complaining of the pain with eye movements, since that the superior rectus and medial rectus are taking origin from the optic nerve sheath. So if the patient is moving his eye, there will be pain with eye movement. This is very important clue in the scenarios about the optic neuritis. There are bright flashes of light with movement of the affected eye, which are called phosphenes. The patients may report diplopia or nystagmus, which is characteristic kind of nystagmus. It's called, the patient has internuclear ophthalmoplegia. So, and can present also with nystagmus. So it will be like ataxic nystagmus of the abducting eye, as we are going to discuss later on in the next lecture. The patient will have a sudden worsening of vision on exercise or increase in body temperature. This is what is one of the very hot clues in the question scenarios. If the question is saying to you that the patient is having problems that appears on increasing the body temperature or when he is exercising, this is called OTHF phenomenon. And the OTHF phenomenon is a phenomenon where the sudden increase or increase in the body temperature after a hot bath or after exercise will cause decrease in the visual acuity because of the increase in the demyelination. So this activity, this increase in the temperature, will fasten the process of demyelination, causing further increase in the visual acuity. Some general symptoms of demyelination. So the patient doesn't always have to present with ocular symptoms. They can present with the general symptoms like dysarthria, dysphagia, electric shock-like sensation on neck movement, which is called Lormet sign. This also was asked before in the MCQs. Weakness and stiffness of lower limbs, numbness and paresthesia, sphincter disturbance, and past history of previous attacks. So all these can be present in a patient with multiple sclerosis. Regarding the signs of multiple sclerosis, what will be the signs? Well, there will be impairment of the optic nerve functions. What are these optic nerve functions? These will be the vision, the visual acuity, the contrast sensitivity, the color vision, the light brightness appreciation, and the visual field. So how can we relate to this regarding the optic neuritis? For the pupil, there will be a relative afferent pupillary defect. And a very important clue about the optic neuritis is the color vision. As the color vision is severely impaired, it is disproportionate to the effect of the drop of the visual acuity. This is characteristic for optic neuritis, meaning that the patient could have a visual acuity of 624 or 618. However, he can see only 3 plates of the Ashihara plates, meaning that there is discrepancy between the color vision and the visual acuity. The visual acuity is mildly affected, but the color vision is severely affected. Okay, also this has been asked before in the clinical exams. The optic disc can be normal or it can show papillitis. So it can be show papillitis. There will be swelling of the optic disc. They can show disc hemorrhage. They can show splinter hemorrhage, and there will be obliteration of the cup. There will be obscuration of the margin. So all these can be present as papillitis. However, the more commonly to present as normal. So there is a common saying about the optic neuritis that the patient see nothing and the doctor is see nothing. Patient can see and the doctor can see. Because when the doctor is examining the patient, he will see a normal fundus. However, the fundus doesn't always have to be normal. Sometimes it can show periphlebitis. The patient can show inflammation of the blood vessels. You can see that there is sheathing of the blood vessels here. Also, the MS is one of the common causes of the intermediate uveitis. We are going to discuss this in the uveitis section. You can see there is cotton balls present in the uveal tissue, meaning that this patient has intermediate uveitis. Or it can be associated with neuroretinitis. So there will be macular star and there is optic disc swelling. So this patient has neuroretinitis caused by multiple sclerosis. Not only the neuroretinitis caused by multiple sclerosis, but for other causes as well. But it is a differential diagnosis. So this is what will you expect when you are seeing a fundus of a patient with multiple sclerosis. So let's say that you are suspecting a patient with multiple sclerosis with this criteria, with this history, with this demography, with this clinical presentation, symptoms and signs, and now you are investigating. Like if you are asking if I need to only have one investigation to hit the diagnosis, it will be the MRI. So you do the MRI with contrast and fat suppression. So you do the MRI with gadolinium contrast and fat suppression in order to enhance the appearance of the periventricular plaques. So this is the gold standard for diagnosis of multiple sclerosis demyelinating optic neuritis. You can see that there are demyelinating plaques here and here. So why we do the contrast? Well, it will show enhancement of the new lesions. So if there is no enhancement, what should I do? Well, you do nothing. It will be just old lesions or old attacks. So you only treat the acute active lesions. So is it the enhancement only that what matters in the MRI? No, it will also, what matters is the number and the size. The number and the size of these demyelinating plaques, because the larger the number, the larger the size, the more incidence of recurrence and the more incidence of development of what is called the clinically definite MS or clinically definite multiple sclerosis. So as I was asked before in the ICO exams, if it is more than 3, there will be more. If it is 3 or more, there will be around 72% chance of development of clinically definite MS over the next 2 years. What's next? What else? We can do visual field. So the visual field can show characteristic, the most common, which also was asked before in the ICO exams, the most common to see decreased sensitivity in the central 30 degrees. The next common visual field effects is that you find a central or centrocecal scotoma, and also arcotoscotoma and altitudinal defect also can occur. So here is the trick. Always watch carefully for the language in the exam. Like if they are saying what is the commonest visual field defect, well, it will be the decreased sensitivity in the central 30 degrees. If they say that the arcotoscotoma or altitudinal field defect never happens in the multiple sclerosis, this will be wrong. Although it is rare, but it can occur. If the MCQ says it can occur or it may occur, this is correct, because altitudinal field effect can occur. If you say the altitudinal field defect is the most common with multiple sclerosis, no, the altitudinal defect is most common with the ischemic optic neuropathy, not the inflammatory optic neuropathy. So always watch out the manipulation of words. The words most common, the least common. It can occur. It may occur. It is the most. It never occur, or never happens. So all these should be very carefully watched in the exam to avoid losing precious marks. The CSF can be also used for oligoclonal bands. So the exam may ask you, so should you do, what will be your next step? Or this is a very common question in the ICO, like they are bringing you a scenario of the MS and tell you what will be your next step to diagnose. So you have different investigations. Would you do CSF analysis for oligoclonal bands? No, because actually this is an invasive investigation. And you are always trying to be the most conservative or least invasive. So when we do CSF for oligoclonal bands, for cases of atypical optic neuritis, as we are going to say later on. The VEP, or the visual evoked potential, also has a role in the demyelinating optic neuritis. So basically, this is one of the electrophysiological studies which will show different negative waves and the positive waves. So this will be the first negative wave, first positive wave, this is the second negative wave, and this is the second positive wave. And in those patients, the first negative wave, it is called N1, should be appear at 95 milliseconds. In cases of optic neuritis, so it's called N95. In case of multiple sclerosis, there will be delayed conduction. So this N1 will be delayed. You can see this is the N1 normally, and this is the delayed N1 for cases of optic neuritis. So this will result in delayed conduction. So those patients will we can see like the N1 can appear at 111, 10, 120, 130 milliseconds. This indicates a delayed conduction. Finally, the OCT scan can be useful for detection and the quantification of the optic atrophy. So it is not used for diagnosis. So it is just after you made your diagnosis, and you want to follow up the patient for progressive loss of the retinal nerve fiber layers, then the OCT will be of great value here. It can show the thickness of the retinal nerve fiber layer, and it will show the loss of the retinal nerve fiber layer in the course of the disease. So all these are different investigations, but as I told you, the gold standard will be the MRI with contrast in order to diagnose the demyelinating optic neuritis. So what about the treatment? Once you diagnose the optic neuritis, you found the plaques in the MRI, what should you do next? You should do the treatment. The treatment is by pulse steroid therapy. There is a famous study, it's called Optic Neuritis Treatment Trial, that said that in order to treat those patients, you should give them methylprednisolone 250 milligram intravenous every 4 hours or every 6 hours for 3 days. So pulse steroid therapy, 1 gram per day for 3 days, followed by prednisone, oral prednisone, 1 milligram per kilogram per day for 11 days, then tapering rapidly of 20 milligram per day for the next 3 days. Okay, so you do induction of pulse steroid therapy, of intravenous steroid therapy for 3 days, followed by oral prednisone, followed by rapid withdrawal over 3 days. Okay, so according to the optic neuritis treatment trial, they mentioned that this regimen will be important to fasten the recovery. So it will improve the duration or shorten the duration of the symptoms. Like if the patient is a secretary and has high visual demands and she needs to get back to work rapidly, so this will be important to fasten the recovery. However, it doesn't have any effect on the final visual outcome. So in this trial, they compared the patients who had a treatment of pulse steroid therapy and other group of patients who had oral steroid therapy from the start, and a third group of patients who didn't receive anything or received the placebo. They found that after 6 months, all patients had reached the same visual outcome. So the final visual outcome is the same, regardless if the patient received the treatment or not. But the value of the treatment that they are suggesting of intravenous steroid followed by oral steroids is that it will fasten the recovery, and also it will decrease the incidence of clinically definite multiple sclerosis in the second or in the next 2 years. So those patients had less incidence of development of the systemic disease. Okay, so what about those who received oral steroids from the start? It is contraindicated. The most important finding about this study, and it's asked always in any clinical exam or oral exam, is if you should give oral steroids for those patients from the start. Well, the answer is no. It's contraindicated because it was found that giving those patients oral steroids from the start, this will increase the risk of recurrence, either in the same eye or in the other eye. So you shouldn't give those patients oral steroids from the start. Okay, so now you know the rule. It doesn't affect the final visual outcome. It will just fasten the recovery and decrease the incidence of clinically definite MS in 2 years. Aren't there any other treatment for multiple sclerosis optic neuritis? Yes, there was another treatment that was suggested by a group called the CHAMPS group. So it was the interferon beta 1A. The interferon beta 1A for optic neuritis is called the controlled. It is based on a study called the Controlled High Risk Subjects Avonex Multiple Sclerosis Prevention Study, or the CHAMPS study. This study suggested that for those patients who received the pulse steroid therapy, they further give them the Avonex or the interferon beta 1A. So the patients received 1 gram of intravenous methylprednisolone for 3 days, followed by an oral prednisone taper, then weekly intramuscular injection of Avonex. So what was the result? The result that this drug will also decrease the incidence of clinically definite MS over the next 3 years. So it will decrease the incidence of recurrence of the chronic disease or the development of the systemic disease. And this is very important for those patients because demyelinating optic neuritis is a very debilitating disease. Okay, so back to the prognosis. What will be the prognosis of this disease? Actually, it has a good prognosis in respect to the ocular disease. So the majority of patients, the vast majority of patients, around 94% of patients recover vision of 20/40 or 6/12 or better at 5 years. So most of the patients recover a very good visual acuity. If the patient didn't recover within 1 month or still having deteriorating or progressive deteriorating vision, then think of another diagnosis. It is not the typical multiple sclerosis optic neuritis. It could be a typical optic neuritis, as we are going to say now. So those patients, because the rule for MS demyelination is to have recovery. Only 3% have worse visual acuity, like 660, or worse visual outcome at 5 years, depending on the MRI finding. As I told you, the clinically different MS overall risk over the next 15 years is 50%. But it will increase to 72% if a patient has more than 3 lesions or 3 lesions or more. So this is the value of the MRI. It is not only for diagnosis, it is also for prognosis. It will help you to determine whether this patient, what will be the risk of this patient developing the clinical systemic disease or not. Okay. Finally, the typical versus atypical optic neuritis. So all we have been discussing is the typical optic neuritis. So what is meant by the atypical? Atypical optic neuritis, it is in contrast to the typical optic neuritis that have different features and doesn't show the full recovery that, or the most of the cases of recovery that what happens in typical optic neuritis. So for typical optic neuritis, it tended to present acutely, while the atypical, it is chronic. In typical, it is young patients, as the mean age in optic neuritis treatment trial was 32 years. In atypical is older patients. In the typical, it is more in Caucasian females, but in the atypical, it is more in males. So everything is different. Laterality for the typical is tend to be unilateral. 2/3 of cases are unilateral, as we said. But for the atypical, it is bilateral simultaneous or rapidly sequential, which may denote, if you are just thinking about it, you may consider that there is something going on. There is like some sort of intraocular inflammation that is affecting the eye and then the other eye, or any cause of systemic disease that will cause intraocular inflammation. The pain is in the typical optic neuritis is present in more than 90%. And this will help also to differentiate optic neuritis from non-arthritic ischemic optic neuropathy. In the atypical, there will be no pain. Optic disc, it appears normal in 2/3 of case. In atypical cases, there is significant papillitis. Again, there is another difference. Hemorrhage, usually not seen in the typical, but there is marked hemorrhage in the atypical. Exudates are uncommon in the typical, while it is more common in the atypical, which means that there is again an underlying inflammatory process that is also involving the retina, leading to macular star. Uveitis is rare, while uveitis in the atypical optic neuritis, like there is paraplanitis, choroiditis, and the phlebitis. And so this, let me tell you that this is usually occurs due to syphilis, due to Lyme disease, due to cases that will present with intraocular inflammation or panuveitis. So actually the optic neuritis is a part of panuveitis. So don't just say the patient or watch the fundus of the patient. You see optic disc swelling, so it is an inflammation. This is an optic neuritis. I will treat the patient as demyelinating optic neuritis. No, consider that this could be a typical optic neuritis, which is a part of panuveitis. The course, the vision usually worsen over the several days to 2 weeks, then begins to improve. So the improvement over less than a month is the rule here. Usually 75% recovers visual acuity of 6/9 or better. Here, there is lack of improvement or progression. So the limit is like 1 month. After the optic neuritis in 1 month, it should be recovered, but it is still progressing after 1 month. This is atypical, and this should warrant the diagnosis of atypical optic neuritis. Okay, So to summarize, this is the demyelinating optic neuropathies, which is the most common cause of optic neuropathies, but there are other causes of inflammatory optic neuropathies. So to summarize the differences between the different causes of inflammatory optic neuropathies, we have the demyelinating and the neuroretinitis, para-infectious, infectious, and non-infectious. For the demyelinating, it is commonest in adults, more common in the middle age, and tended to be unilateral. And there is a marked loss of color vision. So these are the key features about the demyelinating optic neuritis. And also the pain, it is very important clue in the scenario. For the neuroretinitis, present with papillitis and the macular star. So there are a lot of causes for neuroretinitis, such as multiple sclerosis, such as cat scratch disease, and we will discuss it also in the uveitis. For para-infectious, it is commonly in a child, tend to be bilateral with history of viral infection or vaccination within 3 weeks. So when you see in this scenario that it is a child or it is bilateral with history of viral infection, or was a viral prodroma and there was a history of vaccination, don't think of demyelination, think of para-infectious optic neuritis. And they are treated by steroids as well. Infectious. Sometimes the optic neuropathy can be an infectious in origin, like it could be sinus related, like spread of sinus infection, cat scratch disease, which will cause neuroretinitis, syphilis, Lyme disease causing atypical optic neuritis, as I just told you, cryptococcal meningitis, varicella zoster virus. For non-infectious, it can be inflammatory optic neuropathies, but it is due to non-infectious causes, such as sarcoidosis or autoimmune diseases, such as systemic lupus, which can cause both entities of optic neuropathies. It can cause retrobulbar optic neuropathy and anterior ischemic optic neuropathy.